When I see a female patient walking into my office for a consultation, my approach is somewhat different than when I see a male patient. And the reason is because women patients don't thin in the same types of patterns that men do. Rarely do we see a bald woman either in the front or the back of the scalp. Occasionally we see patterns that develop very similar to male pattern hair loss, but oftentimes the thinning is very different. So the workup is going to be different, the evaluation is going to be different. Sometimes I will advise a patient to see their dermatologist before I take up the evaluation, but oftentimes patients find it more convenient to have a hair restoration specialist handling the entire evaluation. So the first thing I will do is get a history, a family history, as well as a personal history of hair thinning. Then we will take a look at the patient's hair and scalp using a dermatoscope to map out the areas where the hair is being affected to determine whether or not there's any evidence of scarring, any evidence of redness or inflammation, and to determine where hair miniaturization may be occurring. Then I will likely suggest a series of laboratory tests looking at hormone evaluations such as estradiol, testosterone, prolactin, thyroxine, dihydroepiandrosterone, or what we call DHEAS, which is one of the more potent androgens in the serum of women. I will also recommend that women evaluate some of the more pertinent vitamin levels like vitamin D and iron, because it is often the case that a woman may have non-anemic iron deficiency. We know that iron deficiency may not show itself as anemia, but nevertheless, low levels of serum ferritin make it harder to treat hair loss and make hair more fine and fly away. So these are some of the evaluations that we will undertake based on a case-by-case basis. Women who are vegetarians are much more likely to have iron deficiency because vegetable iron is much less bioavailable than meat iron, or what we call heme iron. So those are some of the blood tests that I would recommend for patients, female patients who come into my clinic. Once we've evaluated the scalp using the dermatoscope and obtained the relevant blood work, typically I would recommend to a patient who appears to have any evidence of scarring or inflammation that we perform a scalp biopsy. And the purpose is to identify the types of hair loss that can cause scarring. Those types of hair loss should not be subjected to surgery unless they have been quiescent for several years. At that point, we could consider an evaluation for surgery, but other than that, the patient should then be considered for medical therapy. Surgery in female patients is much more selective in terms of those who I would recommend to undergo surgery. For women who have hair loss relative to cosmetic procedures, alterations in their hairline, that's an easy circumstance where typically hair restoration can recontour hairlines and provide a better frame to the patient's face and cover up scarring that may have occurred. However, for women who have diffuse thinning, hair restoration may not be an option. Keep in mind that currently we have no way of reproducing hair follicles other than those that come from your own body, and in particular your own scalp. So if we're taking hair from the back of the head and redistributing it to areas of hair loss, we need to be as certain as possible that those hairs are permanent hairs. It's really very important that when a woman considers hair restoration surgery that she be aware of the fact that telogen shock loss can occur after a surgery, and there may be a period of time when the hair will actually look thinner and be cosmetically more difficult to work with until the grafts grow in. Even then, when the grafts grow in, if some of the hairs that were in the original recipient area were already getting ready to fall out relative to the process that caused the thinning to begin with, those hairs may be permanently gone. So planning for surgery in a woman is much more delicate than the type of planning that necessarily goes into surgery for a man.